Welcome, everyone. As I say, my name's Kath Albury. I'm a professor of media and communication at Swinburne University of Technology. I am also an ARC Future Fellow and an associate investigator in the ARC Centre of Excellence for Automated Decision Making and Society. Today, we're going to take you through a bit of a whirlwind presentation, introducing a new model we've developed in the past year for digital and data capabilities for sexual health policy and practice, with my colleague, Dr. Samantha Mannix, and our wonderful guests, Shelley Carr from ASHM and Dr. Son Vivienne from Transgender Victoria. As I say, we're going to rattle through today, but please bear with us. Before I begin, I would like to very respectfully acknowledge the traditional owners of the lands on which I live and work, the Wurundjeri people of the Kulin Nations, and acknowledge that the places that I live on today were settled by force. Sovereignty was never ceded, and it always was and always will be Aboriginal land. And I would like to pay my respects to elders past and present, and also extend that respect to all First Nations people who are joining us in the webinar today. Thank you, Sam. So this presentation today, as I said, is a whirlwind introduction to the very first stage of a 4-year project funded by the Australian Research Council. I am leading the project and working on it with colleagues. Dr. Sam Mannix and Caitlin Lermonth is the PhD candidate who is associated with the project. As we will explore in the presentation, this work builds on past research of mine and of my colleagues, including some recent collaborations around data cultures. And you can see the covers of 3 recent publications, Everyday Data Cultures and Data for Social Good, which are both books. Data for Social Good is available open access if you're interested in it. And the Data Capability Framework, which was co-developed with my Swinburne colleague, Professor Anthony McCosker, and a team from the ARC Centre of Excellence for Automated Decision Making and Society. So we are talking today about digital and data capabilities for sexual health, and the question of why that is important. So as I say, I came to this project from work looking at data cultures, but I am a media and communications scholar and a cultural studies scholar. My work really draws on science and technology studies, sociology, a range of interdisciplinary practices. So the question might be, why am I looking at sexual health? Well, I also have a past going back to the late 1990s of working with the HIV sector, often in a very hands-on way, as a facilitator of groups talking about living on HIV treatments for NAPWA. And from about the mid-2000s, I was on a health promotion advisory subcommittee for New South Wales Health. So I've always had an intersecting interest in sexual health broadly, and the ways that we understand and enact, I guess, health practices within digital sexual cultures. I've done work on dating apps and sexting and pornography, a range of topics related to this issue. But I also have, through the years, worked with many health promoters, educators, practitioners, clinicians, policymakers, and I'm really always very interested in thinking about what workforces and organizations and systems and structures bring to these questions, not just the ways that consumers use digital culture for health. So with this project, we initially sought to investigate digital and data literacies within sexual health workforces. But after I was funded, I learned very quickly that there is right now a Commonwealth strategy being enacted to convert the National Digital Health Capability Action Plan, and you'll see the diagram on the screen right now, giving you a sense of what that looks like, into a digital health capability framework. And the digital health capability framework, which will be launched in November this year, is going to be quite directive in terms of talking about what health workforces really broadly need to be able to know and do in relation to digital tools and digital technologies and data practices also. So my project, as I discovered, aligned really well with this very timely kind of national conversation. But as I say, the National Capabilities Action Plan is talking about the health sector very broadly. I'm really interested in the ways that issues like gender and sexuality might complicate digital and data capabilities for healthcare. And that's why I'm specifically talking about the sexual health sector in my research. Sam, can we please have the next slide? So this is a project overview, and I will say we're launching my report today. There will be a report link in the chat for you shortly, and you will also see a link to the report in one of the slides coming up. So I'm not going to read through the text-heavy slides in detail, but this just gives you a sense of where we're at. It's a 4-stage project. We are at the stage, the end of stage 1, about to commence stage 2. What we have done so far is to benchmark current understandings of digital literacy and data literacy within sexual health literature. And we've also conducted interviews with a range of researchers and policymakers in the field of sexual health and digital and data studies. And those are the findings we're going to present to you today. And I'll hand over to Sam to take you through that content.
Thanks, Kath. As Kath said, in order to get a better idea about the way that digital and data literacies, as we were framing it at the time, do or don't arise within sexual health contexts, whether that's practice, research, or policy, we conducted both a social sciences narrative review of the literature, and we complemented that with interviews with senior researchers and practitioners in sexual health and allied fields. You can see here the literature review method consisted of a database search for terms in the column on the left. With duplicates and unrelated results removed, we had 30 papers. There were no results within these search terms with data literacy. However, as I'll explain a bit later, that considerations of data did emerge throughout the literature. For our interviews, we recruited primarily from existing networks, with some snowball sampling kind of going after that, and completed our final interview in March this year, interviewing 30 people in total. You can see here the spread of expertise and experience of our interviewees, which gave us sort of that diverse insight. And also some of our interviewees in particular were able to give us some really holistic views based on the different hats they wore within their organizations or universities. So thinking about some people acting as clinician, researcher, management, which really kind of gave us an idea of some of the different facets of the issue. So first I'll talk about our literature review findings. Within the literature that we surveyed, digital technologies and platforms were largely seen as sites or systems for the transfer or delivery of health information and or clinical sexual health services. And a large proportion of this work was focused on quantifying and measuring individual digital literacy levels. So digital literacy was discussed as a tool to navigate the proliferation of online sexual health content, or which was kind of spoken of in the literature as information. and the skills to navigate these clinical sexual health technologies. So here, digital literacy was largely framed as a relevant skill for individual consumers and or patients, however that is framed. Within the literature, there was no discussion of the digital literacy of sexual health organizations or sexual health professionals, other than to discuss the importance of considering digital literacy levels of patients and consumers when developing sexual health interventions or sexual health messaging. And as I said earlier, there were no considerations of data literacy specifically in relation to sexual health. Considerations of data did arise in relation to accessing and understanding electronic health records, for example, and these kind of skills were largely considered in relation to the concept of digital literacy. So our findings from our expert interviews. So one of the really big questions that came out was around, what is data for sexual health? So considerations around the way sexual health organizations and practitioners access, understand, and utilize different types of data, and what is that data? So in some instances, organizations didn't recognize themselves as generating data beyond medical clinical practice, so like Medicare data, despite using data-driven platforms and technologies in their health promotion, education, and client management activities. Participants also spoke of the way that expertise and experience, both at an organizational level, so within the organization, and a disciplinary level, so whether that be public health or digital cultural kind of studies, was often siloed, and they identified a need to develop kind of collective and interdisciplinary approaches to digital and data practices. A lack of resources was also identified as a barrier to external collaboration and as a driver of reluctant participation in external projects. So in order to access analysis of some of the data that is generated by a sexual health in organization, there was examples of having to participate in larger projects or larger kind of data practices. Participants also spoke about concerns around digital and data governance structures and accountability. And again, this really spoke to the need for organizational approaches and policies that recognized kind of decision-making processes and ethical principles. And finally, a need to work with young people and or co-design processes to better understand and incorporate their sexual health and digital data practices within organizational policies and knowledge systems was also identified. And this aligns really well with, as Kath kind of outlined, stage 2 of our project. So here we've just highlighted a couple of key quotes that I guess speak to some of the high-level findings of our interviews. Again, we can see here that there is an identified need to consider the digital and data skills and competencies within the sexual health workforce, but also how this might be approached from an organizational level. So you can see one of the participants here highlighting the need for organizational procedures in place to safeguard practices of not only their clients and consumers, but also the staff and the organization. Back to you, Kath.
Well, sorry, I had muted myself. So when we're thinking then about digital literacies and data literacies, which, as I pointed out before, is kind of how we started the project and how we framed the interviewing stage of the project, it became very clear to us very fast that literacies were maybe not the most useful term in this context. Digital literacies and digital health literacies are, as a term, are contested in the ways that the broader term health literacy has become quite contested in the literature in this space, because it doesn't need to be understood this way, but in practice, it's often seen in terms of deficit, and the person who has the deficit is most often framed as an individual health consumer. And that means it's quite difficult for an organization, particularly an organization that has a very diverse workforce with very diverse roles, to begin to think in what you might term a systems thinking way about how to understand and work with digital technologies and data at a broader policy and practice level. So for that reason, we followed the lead of my colleague, Anthony McCosker, and moved to thinking less about literacy and more about capability. And this is drawing on the Data Capabilities Project that we recently worked on with a group of not-for-profit organizations, where we began to think about what sector-wide capabilities might look like in relation to data specifically. And as I say, I'm not going to go through this slide in detail, but the detail is certainly available in our reference list, and you can access this report after the webinar. Sam, we might go to the next slide if that's all right. So when we came to think about what digital literacies might mean for sexual health, we shifted pretty quickly from literacy to capability to be able to think about this larger kind of systematic picture. And again, I won't read this text-heavy slide. The detail is available in our report, which we're launching today, and we will provide the link for in a second. But we're thinking about the ways that digital capability works in sexual health at multiple levels. We're thinking about access and infrastructure, and that's thinking about enterprise platforms and technologies. So things like, your access to My Health Record, or the content system you use for your mail outs to clients, or your email list, but also more vernacular platforms and systems like the digital identity you have on Instagram, and what that means for your outreach work, and what that means for your staff and internal and external policies. We're also thinking about the skills. So how do people manage and work with these platforms at all of the different levels that a sexual health organization might be working with digital infrastructure? And then at the foundation of all of that is governance. What are the policies? What are the processes of leadership, stewardship, accountability? How are community or consumer perspectives incorporated into the ways that an organization manages its digital identity? How are ethics and inclusivity factored in? And then how is risk management accounted for in the organization? What happens, for example, in the case of a data breach, the kinds of things that we're all very mindful of after the Optus incidents earlier in the last 18 months. We'll have the next slide, Sam. Thanks. And so from there, we go then into thinking about data more specifically. What are the data capabilities for sexual health? How can sexual health organizations think about data in a more holistic way than just considering data as the output of a Medicare record, or data as being something that comes back from researchers or from surveillance kind of reporting. Data is something that is generated within an organization. Can an organization access their own data? Can they work with it at local level? Can they work with their constituents, their health consumers, their communities to read and understand the data? These are kinds of the questions that we're thinking about going forward. And again, all of this is in our report, and we really are very keen to talk about this with health organizations going forward. In the next stage of the project, we will be also thinking about digital and data capabilities models for health consumers. This first stage, digital and data capabilities for sexual health policy and practice, as you've seen, really applies to organizations and health workforces. The report is available for download now. Thank you, Caitlin, for sharing the link in the chat as well. what we want to know is how sexual health consumers, particularly 18 to 29-year-olds who are a priority population in Australian sexual health strategies, how they are using digital technologies and digital platforms for sexual health, and more importantly, what they think the workforce needs to know. So where are the gaps in terms of understanding, accounting for, incorporating lived experience of digital and data-driven sexual health among consumers? Where are the gaps in terms of understanding that within an organization and thinking about it, making changes to practice based on consumer needs? So that's where we're going next. And thank you, Sam, for driving the slides so far. And thank you very much to all of our interviewees. I know that some of you are here in the webinar today, and we so appreciate your input. And thanks again to our project reference group, who have really contributed a great deal of expertise to the project. References and further reading are listed on the slide and also in the project report. In the next stage of this presentation today, I'm going to invite two members of our reference group, Dr. Son Vivienne and Shelley Carr from ASHM, to give us a little bit of an insight into what this work might mean for the workforce and what it might mean for consumers of sexual health services. So I'll ask first Dr. Son Vivienne to tell us a little bit about their perspective as a member of the reference group. Son is currently CEO of Transgender Victoria, which is the peak advocacy and wellbeing focused not-for-profit led by and for trans and gender diverse communities in Victoria. Son has a background in film and media production and research, writing and teaching in academia. Their most recent book, Queering Safe Spaces, Being Brave Beyond Binaries, was published last month. It is a brilliant book and I recommend it to you. Son, we'd love to hear from you about where you think this research should be going next and why it's important for your organisation.
Oh, thanks so much, Kath, and thanks for the spruik. Look, so much of this work and the work that you're doing is so relevant to the work that we do at TGV. I'll just give a very brief thumbnail of that work, and then I guess what my particular geeky, nerdy interest in it all is, and then just canvas these kind of lenses of capabilities and sexual health from a trans and gender diverse perspective. In 8 minutes, so keep me to it if I'm going too slow. So TGV is 23 years old this year. It's been a primarily volunteer-led organisation until around 4 years ago. We've now got 10 roles across 7 FTE, so we're still very small with very stretched capacity. Our principal work is in peer support for and with TGD and non-binary community. So I actually use trans and gender diverse as an umbrella that is inclusive of non-binary communities, but the discussion we'll have shortly around categories and code switching across those categories will make more sense of that use of TGD-NB as an acronym too. Beyond the work we do with communities, we are constantly needing to offer consultancy to government and research orgs. Along with Swinburne, we're working with Archers and Uni of Melbourne in various spaces ranging from clinical health and wellbeing for trans and gender diverse people through to the socioeconomic impacts of the world that we live in, I guess, in the Archers space. And then we collaborate with LGBTQI+ orgs nationally. So spaces like Equality Australia and OSPATH, which is the national peak org for medical practitioners working with trans and gender diverse communities. We have a kind of ongoing stake in those discussions, I guess, around political advocacy as well. And so then above and beyond that, we're also, as any of you who've read any mainstream news over the last year would I guess, get a glimpse of how often trans lives are in mainstream media, often with a, call to debate the pros and cons of our existence, which is a utterly demoralizing and exhausting kind of debate to engage in. It goes from our rights to participate in sport, go to the bathroom, fill in registration forms, or participate in the census. So that's kind of the scope of the work that we are doing. And I guess, mention of census, even categories of bathrooms, we often have a male and a female door to choose between, and that has very real impacts on the wellbeing and health for young people, who often actually either don't go out because they are not confident that they'll find a safe bathroom to pee in, or will hold on. So, you can see very quickly what the trickle-on effects of categories that are metaphorically representative in bathroom doors, but also in registration forms and census fields for nuanced data collection or not. In terms of my academic background, like Kath, I come from media comms and cultural studies. I've been really interested in how queer communities, I guess, engage with digital identities to manipulate their privacy and publicness, depending on what they're seeking from the spaces they engage in. And in particular, I worked with a cohort going back a few years now called Scrolling Beyond Binaries, which was a national survey on LGBTQI+ social media and wellbeing. And the final paper that we published out of that, that I led, was called The Social Life of Data: Strategies for Categorizing Fluid and Multiple Genders. So looking back on that now as a couple of years old, it actually is, surfaces, I guess, some of the issues I'm about to talk about within the trans and gender diverse context and the work we do at TGV. Take a quick breath there. Kath, is this all okay in terms of what you're seeking and resonance with our audience?
Crack on.
Cool. Okay, cool. So I guess in terms of the initial work that you've done in the scoping of understandings of digital capabilities, I really appreciate that shift to capabilities rather than literacy. We know that trans and gender diverse people code switch according to what they're being asked, why, and what personal benefits there are for identifying in particular ways when they're asked information about themselves. So this will include things like just scribbling out the categories of if there are only binary options available and filling in their own version outside of the boxes, or really engaging in discussions around best practice at data collection levels globally. And in particular, the census is a really interesting discussion around two-step questions that allow people to have a dominant and a secondary identity that will acknowledge, in some situations, their lived experience of binary gender, but also in a secondary level will point back to their sex assigned at birth and make them visible in terms of curation of stats as a trans person. The other thing, I guess, beyond our capacity to, really engage very proactively around how we shape our own data and engage with data collection, I think it's also really important to have a trauma-informed lens on all of that, because, historically, queer and gender diverse communities have not been well reflected in data collection, and that poor sense of trust in surveys and stats, combined with very variable well-being, and we are largely overrepresented in stats on poor mental health, et cetera, will mean that any data that is submitted is not only open to interpretation by the gatherers of the data, but by the people who are submitting it. So I think this is a call just to be very mindful around the context in which data is gathered, you know, the actual circumstances of the day, whether it's a paper form or a digital form, whether you're in a health clinic or at a queer party, and the variabilities of how individuals will code switch across their range of identities that they can choose from. I think I'm going to be going okay for time. I've got about another 2 minutes. The lens on sexual health is one that is also super interesting to me. You know, historically, we've been very mindful, particularly in training for mainstream orgs, of delineating sex and gender as different things. But we're also now in an era where we are mashing them back up together in a 202 version that actually acknowledges the intersections of both gender and sexuality. The relational dimensions being, you know, for example, a trans woman who comes out to their wife who has historically been in a heterosexual cisgendered relationship, you know, what are the ramifications for the wife's identity? Do they now identify as a lesbian? Or, you know, how does their sexuality actually shift according to the dynamics of a relationship? And in fact, even this 202 version, you can see in discussion, we're currently having discussions with several researchers around the Medical Research Fund, Medical Research, I don't know what the extra F is, Medical Research Futures Fund. And there are some categories that are assigned to sexuality diverse communities and some that are to gender diverse communities. But of course, gender diverse people also have diverse sexualities. So, you know, there's an actively contested kind of discussion around where we're included and where we're focused upon as a priority population. So then, you know, if you're thinking about trans and gender diverse existence as an actual condition of mental health, which is historically, you know, the pathologization that we've grown out of, there are also aspects of sexual health that are core to who and how we are as a result of being different from the sex assigned at birth. So sexual health, therefore, is everything about TGD services, like the capacity for us to access mainstream general practice care for a sore toe without being pathologized as trans, through to sexed health that is also gendered, i.e. cervical cancer and prostate checks that may or may not be offered to us according to how our genders are perceived. And then, of course, the area that we focus on and know most about around gendered affirmation of hormones and surgery. So they're kind of three really different aspects of sexual or sexed or gendered health that are pertinent to trans and gender diverse people, and, you know, more broadly to think about how we're included in data. So I guess when you're interrogating those dimensions, you know, how are these services dealt with at reception in a GP clinic or a hospital, or digital systems related to Medicare or medical insurance? You know, can gender change be accommodated by these systems? Does misgendering prevail in all of or some of those systems? And what happens when the systems are irreconcilable with one another? You know, the data capabilities of systems that do not accommodate us are evident in things like airlines, where to this day, I am asked when I book a ticket as doctor, a gender neutral term, whether I'm a male or a female doctor. I can't be a non-binary doctor. And then things like a non-binary Australian passport, where that identity has been available to us at federal data level for over 10 years, but is irreconcilable as soon as you travel with that passport. You get to US Border Patrol and X doesn't exist in most US states. If your body is identified as having any anomalies when you are scanned through the entry system, you'll have a need to be patted down by a gender that matches that you're presenting. Obviously, that's problematic in a US system where how are you going to find a security guard that also identifies as non-binary to pat me down? You know, there's some really particular clashes and inconsistencies that result from the digital data categories that are available in everyday life. So I guess my conclusion and the takeaway points in terms of how this research is super useful for us, but also the things that we need the research to accommodate for our communities is when and how can trans and gender diverse and non-binary people engage with their personal data and digital capabilities to empower themselves? You know, what is the, I guess, common knowledge and understanding across communities around how they code switch? Some people are really aware of themselves doing it. Others see it as a demand rather than a superpower. And when and how do systems fail to accommodate multiplicity, fluidity, complexities, all of those things being of gender, but, you know, really also beyond gender. Gender becomes a almost arbitrary category in terms of understanding the capacity for data categories to change. So, you know, where there are fluid data categories, how do systems accommodate change? That's it.
Thank you so much, Son, and you, you know, we appreciate so much your participation and TGV's participation in the project, and you've really reminded me that one of the reasons we made the shift from literacies to capabilities in this project was not just the pragmatic alignment with a Commonwealth policy document, but also that capabilities really have a social justice implication when we draw on the work of scholars like Amrat San and Masha Nussbaum. We're thinking about capabilities as freedoms, and really thinking about capability as in the kind of same way we might think about concepts like human rights, like what are our capabilities in the world? What is our access? What is our agency? And that's a really important thing to think about, both for health consumers, but also for members of health workforces who often have really intersectional identities in relation to the different communities that they are part of. So thank you. I'm now going to hand over to Shelley Carr. Again, we are incredibly grateful to be working with ASHM on this project. Shelley is the Strategic Partnerships Manager at ASHM. She's responsible for developing and nurturing relationships with stakeholders to advance ASHM's purpose, and for identifying opportunities for collaboration and growth aligned to ASHM's strategic plan. She has a background in public health and a passion for innovation. Over to you, Shelley.
Thanks, Kath, and thanks, Sam, and thanks, Son, for having me here today. So I recognise that not everyone here will be familiar with ASHM. Many of you are joining from outside the sexual and reproductive health sector. So got a little bit of an introduction to who ASHM is. So we're a not-for-profit member-based peak organisation, and we support healthcare professionals to deliver person-centred care for bloodborne viruses and sexual and reproductive health. We work collaboratively to strengthen workforce capacity and health systems in Australia, Asia and the Pacific, and we do that through the development of a comprehensive range of resources, clinical guidelines, education and training, as well as coordination of knowledge exchange, events such as conferences by our award-winning conference and events team. So that's ASHM, and I think hearing from Son just reminded me why this is so important for our sector. And Son, I hear you on the 8 minutes is for everything that we want to talk about is so small. So if we can go to the next slide, Sam, I have tried to break down what digital and data capabilities means for ASHM, our members and our sector. And I've kind of put it into 3 broad themes. So what it's meant internally for our organisation, what it means at the interface of ASHM and our audience, so our members and the health professionals and communities that access ASHM's resources and guidelines, and what it means for our sector when we're and how we can support digital and data capabilities more broadly. So as with most organisations over the last few years, we have found ourselves knee deep in a digital transformation journey, which is super exciting, but at times can be a little intimidating. So internally, what that's meant for us is we've created a digital transformation roadmap, and we're investing in expanding our capacity in this area. So for example, we've got new skills and positions that previously didn't exist within ASHM, things like user experience professionals, developers, and we're also supporting our current staff to upskill within these areas so that we can deliver these new digitally enabled resources as well as new digital tools within our organisation to support the work that we do. So then that's all to facilitate that interface of ASHM and our audience so that they can find the information that they need to guide their clinical decision-making. You'll see I have put up one of our really great tools, which is our interactive syphilis decision-making tool, which steps clinicians through screening for syphilis. And this is one of many of the digitally enabled tools that we have on offer. But I think now we're starting to think more longer term and more broadly about our tools and resources for someone to be able to use, say, the syphilis decision-making tool. They need to know it exists. They need to know where to find it. So we're kind of starting to think around integration of our resources and the information that we are experts in, and how we integrate that into existing tools and digital technology that our members and health professionals already use. We are thinking around we're up to enhancing our website, so including things like to improve accessibility. Lots of opportunities here for digital technology to be improving our website so that people can find the information when they need it. So for example, enhanced smart navigation tools that will not only give you the right search results, but will take you to the information that you need in the language that you're searching in. Will suggest it's relevant to the jurisdiction that you're searching from, and may even provide information that you didn't even know you needed, but is very relevant to the information that you're searching for. So yeah, this is the start of our journey into this area, and it's very exciting. But then I think the final way that digital and data capabilities for our sector is important is how does ASHM support the health workforce to access and use these digital tools and access and use data to inform their clinical decision making. And I have a bit of a use case on the next slide. So if we can go, so this, for example, it's not sexual health, but it's within our sector and within the work that ASHM does. So it's a hepatitis C case finding project called Beyond the Sea. And this project, we are supporting 150 practices across Australia to identify people who should be offered testing by interrogating their electronic medical records. So it's important because it supports practices to develop the skills to understand and use their data. And also contributes to our elimination goals as well. So it's a super exciting project. Some of the barriers that we've identified is that, so for example, searching medical records often relies on digital technologies that don't always speak to each other very well. So for example, lab results aren't displayed within electronic medical records that can be extracted by the extraction tools, which causes lots of issues. So that it becomes quite a manual, still a very important task, but quite a manual task to search patient medical records and audit them, make sure that they have all the right information in them. But as you'll see from the quote on the slide, it actually supports practices to embed quality improvement and quality data practices within their practice as well. So really getting in and amongst the data is useful as well. And I'm also going to speak about another hepatitis C case finding project called Discovery HCV, which is funded by Gilead and is being coordinated by IQVIA. And I'm on the steering committee for that. And that's looking at using machine learning and AI to use algorithms to identify patterns within patient medical records and flag patients that might benefit from hepatitis C testing. So it kind of bypasses that very manual search, but it doesn't solve a lot of those issues around data integrity and understanding and using data as well. So I think while there's so much potential, and I can see lots of synergies in how these two projects hopefully can work together to really solve some intractable issues, not just in hepatitis C, but across the board when we're kind of using patient data and supporting practices to be able to use and access their data. I think when we're talking about things like machine learning that has the potential to scale up things like scale up solutions like case finding, it comes into play the ethical considerations. So, for example, if we implement a machine learning algorithm that identifies patients who may not ever realize that they've been at risk, calling those patients we're dealing with sensitive information. So that could be an issue for the patients who are being recalled as well. So I think we need to, while there's some really exciting ways that we can implement these new technologies, it does also have the potential to cause harm. So we need a digital and data capability framework to guide some of those decisions. We need really good governance. We need lived experience, kind of leading and being part of those decision-making, not just kind of telling us what works and doesn't, but really being involved in that decision-making. And I think when we're using these big data and tools, automated tools, we need to remember that they are accessing data that was inputted by humans. So it does also have the potential to replicate biases that are already inherent in the data. So really critically thinking about the data that is coming out when we're using those algorithms is really important as well. So yes, a digital and data capabilities framework when we're rapidly moving towards projects like this is going to be essential as we move forward. So yeah, really appreciate being involved in a project like this.
Fantastic. Thank you, Shelley. Thanks so much. We have about 10 minutes for Q&A. We would probably be best served by people typing questions into the chat just because of the way the meeting's been configured. So I'm going to stall for time somewhat while people, to give people a chance to do some typing. I'm always really slow doing that in the chat. We welcome questions in relation to the research project itself, thinking about digital and data capabilities in relation to sexual health, and also thinking to the ways that members of our project reference group or other communities or workforce representatives might best be involved with the project going forward. While I am giving people typing time, I also would like to correct, I garbled my speech earlier on. The scholars who are most often cited in relation to the capabilities approach to social justice are Amartya Sen and Martha Nussbaum, and I incorrectly pronounced both their first names when I was introducing them before. Do we have any questions in the chat? It may be that thinking about digital and data capabilities are new to some of the participants from the health sector. It may be that they're not. It was really interesting for Sam and myself when we were completing the final interviews this year and developing our report, to reflect on how the conversations have changed just in the past 12 months around data and digital capabilities in the space of health. Many people were quite surprised when we first talked about this project and really saw digital literacies as something that health communities need. Digital literacies, health consumer communities, I should say, they need digital literacy so that they don't believe misinformation. When I asked kind of what we need as people who might be providing services or care or information, education for that matter, people were less clear on how digital capability or data capability might work in a workforce. That doesn't seem to be the case now. There are quite a few quite advanced conversations going on in the sector, I think. We have a question from Stephanie Livingston. When we complete the second phase of the project with health consumers, will we be focusing on specific community groups separately, i.e. people with a disability, young people, etc.? The project is specifically scoped around, as I said, a policy-defined priority population. And I always do the scary bunny fingers for that because it's such a strange way of thinking about groups of people. In the national STI strategy, young people are defined as a priority population. Young people in terms of policy means all people residing in Australia aged 12 to 29. So it's a pretty vast category. For the purposes of this project, I'm most interested in people, the views of people 18 to 29, because I think a lot of sexual health promotion and certainly education has really focused on school-aged young people, and a lot of resourcing has gone to thinking about school-aged young people, less so about the kind of diversity of sexual practices, behaviors, needs of people 18 to 29, who are more likely to be sexually active, more engaged in, all kinds of consenting digital sexual practices that they are allowed to do by law. So there's different debates than there are about under 18s. And I was really interested in focusing on that group. We are working with people from our project reference group to specifically include workshops with people with a range of experiences, but there won't be a separation of this is a group of people with disabilities, this is a group of such and such. We're working with peer researchers for this process, so it will be researchers who have links to specific communities, but they will also be facilitating workshops with a range of people. Capabilities is a good framework. We have a query. I'm wondering how underpinning values, ethics, principles are inscribed in this work, i.e. institutions and people want different things from data and governance. That is a good question, Anthony. We are at the end of year one of a 4-year project, as I said. And so it's going to start, I think, with this development of high-level thinking and frameworks. The question will be, yes, how does that play out in practice? How do underpinning values, ethics, and principles get translated, particularly once we have the rollout, which we will have in November, of a national top-down capabilities framework. So that is coming, and that's what we're also preparing for, is there will be a digital capabilities framework based on the National Capabilities Action Plan, and that's going to instrumentalize what the kind of Commonwealth policy-driven version of data capabilities are and digital capabilities. That's not going to necessarily be the same kind of understanding of digital and data capabilities as we have found from this more bottom-up version of inquiry. And the dialogue between, I guess, the top-down and the bottom-up is going to be a really interesting space to work in. We are very close to being out of time, so I would like to thank all of our participants again. We would love to hear more and work more with people who are interested in this space. Sam and I are very happy to give more detailed versions of the findings and discuss them with anyone who's interested in discussing them. And we are, of course, working on some more nuanced academic publications out of this work at the moment. We look forward to seeing people again, and thank you very much for joining us today.